First thing is welcome to the very first part of this process. Now, I hope we've all come with the same expectation this afternoon. We will not be offering you a comprehensive training on this online session. This is purely an opportunity for us to introduce ourselves and for you to ask any questions or clarify any points about the actual face-to-face training that you'll be doing with us and the palliative care team within the simulation centre at some point later in the year. So this is not your actual training today. This is just an introduction where we're going to look at a few concepts, share a few ideas, give you the option to ask any questions and put your mind at rest about anything you're not sure about. So just so we're all going in with the same expectations. So for this afternoon, broadly, we're going to be looking at two things. So Rebecca is our communications expert here, so we're going to get her to just talk you through some slides that she's prepared so that we can have a little look at some of the ideas around these challenging conversations. And then once she's kind of taken you through a very brief sort of introduction session there, then Katie and I might explore some ideas around how we're going to use simulation to give you the opportunity to kind of reflect and to act and to really practice some of those challenging conversations within a safe space. But I think it's really important that we let Rebecca sort of tell you that why we're doing this training in the first place. So if it's okay, Rebecca, I'm going to let you talk.
Thank you, Paul. So I think the first thing to recognise in this situation is that talking about death and dying is challenging for all of us. It's not an easy thing to do. In the cohort of international nurses, it's even more difficult because we know from working with you guys on the fundamentals of nursing course that there's lots and lots of challenges around the cultural difference around end-of-life care and how that differs from NUH and the expectations that NUH has of you as nurses, and having some of those really tricky conversations. So the first thing I want to sort of recognise is that this is very difficult, and we are aware of that. It's very challenging. It's a very emotive subject. With that in mind, I guess there is a privilege here that we can do this in a safe environment, somewhere that's supported. This isn't a test. It's not a test that you pass or fail at the end of it. The simulation team are brilliant at sort of making you feel at ease. So I wanted to just acknowledge really that this is uncomfortable, but we are going to do this together. With regards to the subject itself, communication around death and dying, it would be really helpful if you guys can do a little bit of homework beforehand and familiarise yourself really with the SWAN model of care. So you will know from the training that we've done with you that NUH has a SWAN model of care that is put in place when anybody is in the last days of life. But in your areas, you should see this leaflet. And in this leaflet, it's got everything that you need to know around supporting families at the end of life. So in here, you will see this leaflet's aimed at loved ones of patients that are dying, but it's got lots and lots of information. So it talks about why we've given this leaflet. It talks about visiting hours, special wishes, and how the focus of care has been switched to comfort care. And then it's got it talks about some changes that you may see when a patient's dying. So things like why they're not eating and drinking, the changes you might see to their breathing pattern, recognising that they may become a bit more sleepy, and symptoms such as restlessness and agitation. And then you'll also see a little bit there about spiritual care that we provide at NUH or that we offer. And then the last page of the leaflet will just talk about meeting the needs of children, the opportunities we've got to create some memories for patients and families, and tissue donation. So if you guys can have a read of that, that will really prepare you for the simulation and the things that you may be asked to consider in the simulation that you do it. So that's a really helpful resource for you. The other thing that will be really helpful, if you've not already seen it, it is part of your mandatory training, so you may well have come across it, but if you're not familiar with the SWAN model of care, everything you need to know about it is covered in this video. There is a link on the hospital intranet page, so if you were to go on the NUH internet page and type in palliative care, there will be a link for this video. It's also part of your mandatory training, so again, if you can have a look at that before you come to your simulation, that would be really helpful. And then finally, there's just another resource here for you to help you prepare. And this is one that's not, you may not have seen as much as the SWAN model of care. And this is around caring for a deceased patient. So when the patient's died, you are expected as a registered nurse or healthcare professional, HCA, to provide what was called last officers. So the personal care that you deliver to a patient when they've died. All of those sort of clinical guidelines on how to do that are all included in this video. We won't show it today because again it's 7 minutes long. It will become part of the Trust mandatory training at some point, but it's just really helpful for you going into this course to familiarise yourself with that if you can. It covers things from taking into account spiritual considerations at the end of life, cultural considerations, and all the other practicalities that come with nursing. So it's really, really helpful for you if you have a look at that before you come onto the course. I think that's pretty much it from a speciality perspective. We could go on and on with palliative care, but I think it's more important that you kind of get an understanding of what simulation entails. So yeah, I think that's it from me at the minute, Paul, unless you've got anything you want me to add in there.
No, that was wonderful. Thank you. I think you've really laid that out very nicely, and the value that we're kind of placing on this opportunity to kind of offer some training. No, I really appreciate that. So again, when we started to think about this course, Rebecca and her colleagues, Laura and Alison, came up with what we thought were some amazing kind of learning outcomes for the course itself. So this is not for today, this is for when you come back to us for your actual sort of live face-to-face simulation training. And I think it's well worth having a quick look through those now, just so again you have a sense of what we're trying to achieve, what we're trying to provide. And I think these are some very achievable learning outcomes for us. So initially, I guess you would term that as a blanket around assessment, so recognising distress, utilising all of those communication skills that I'm sure you all have as healthcare professionals. So the ability to listen effectively, to offer pause for your patients and relatives to think and to consider, and empathy whilst communicating with people at a very difficult point in their kind of life journey. Some of what we may talk about on the course itself may revolve around dealing with some of those complex symptoms that may present themselves to your patients at the end of life. Rebecca's already done a great job of talking through the SWAN model, so I won't say anything else there. But I think really the final one of these 4 learning outcomes for me is it probably says it all. It probably sums up everything that we want, which is to kind of give you the opportunity on reflection to think about how we can all be more sensitive and more compassionate in those difficult times with our patients. So I think that's a very reasonable set of learning outcomes for us to explore, and I hope we can do them justice in your training that we'll be providing. So we've talked around issues of palliation. So now I guess the next thing to think about is how we're actually going to go about delivering this training, the mechanism for training, which is going to be simulation based. So now we know that simulation is a very broad church. So when we talk about simulation training, what we are absolutely not talking about in relation to this course are OSCE, where you might have had a simulated patient either with a human or a mannequin, and you would be expected to work through a very structured process, maybe of assessment. and potentially treatment of some commonly encountered issues, and you would have been marked against a sort of accepted scheme, or maybe resuscitation training, where you would need to evidence your skills of being able to follow through the process of cardiac resuscitation. So that's what we're not going to be doing in simulation. And I think Rebecca already mentioned that early in this presentation, that this is not a test. This is not an OSCE. This is not an examination. This is not a process where we're expecting to criticize you or to give you a mark. This is just an opportunity to step outside of your day-to-day practice into a safe learning space here at the centre, where we will give you the opportunity to do some simulated practice around some challenging aspects of care, and then give you the time and the support to reflect on what's happened and why we behave the way we do, and how we might seek to potentially modify our behaviour in some cases to get a more favourable outcome for our patients and for our loved ones, and also for us. So it's very much about looking for positive development opportunities, about constructing a better experience for us and our patients. What simulation isn't? Well, we've got some pictures here to jog my memory. So if we start, wonderful actress there at the top, we're not expecting you to act when you come to simulation. Nobody will ever give you a script to follow. Nobody will ever ask you to be anything that you're not. So if you are coming as a registered nurse, we would expect you purely to act as you would do if these situations were real on your ward. We're never going to ask you to be a surgeon or an anaesthetist or anything outside of your normal professional role. This is not an examination, so we are never going to be asking impossible questions. We are never going to be putting you under test conditions. We are simply going to ask you to do what you would do in a real life situation, and then have a little chat about it afterwards. This is not role playing. So we only ever ask you to act within the limits of your own capability, and we will never ask any more. We keep coming back to this phrase, the safe learning environment. Now, what we mean there is this is somewhere you can come and practice and then reflect. Now, that's something that very often we might do alone and we might do in written form, but actually within the simulation space and within the simulation-based training, what we're going to ask you to do is do that reflection as a very small group and to support each other. The faculty will also be there in that conversation, and we will maybe ask some questions to sort of spur on your thinking. We might make some observations of our own, again, just to kind of move along your thinking. But fundamentally, the thing we're most interested in is your ability to share with us your ideas and your reflections on your practice, because that way all of us will learn collectively. But this is very much a non-judgmental space, so we want you to feel free and able to share your thoughts with the knowledge that anything that you say within a simulation discussion will go no further, and anything that is said, we will all respect the confidentiality of that conversation. So when we talk about safety, what we're looking for is sort of three fundamental domains. So we want you to be safe physically. So we will make sure that you are orientated to the training space. We'll make sure that you're aware of any potential issues that might arise in training. We'll make sure you're aware of fire exits, and we want to look after you physically. We also want to look after you psychologically. We appreciate that when you perform with other professionals, you know, they might be your colleagues, they might be your friends, potentially, depending on which day you attend, it might be a room full of strangers, but you are basically sharing your professional practice with others. And we know for some people that can feel a little uncomfortable, but we really want to foster this idea of safety and shared learning, shared reflection, so a community of practice. we also want you to feel emotionally safe. And I think this is something that maybe I won't say too much about now, but I think potentially we might ask Rebecca to have a little sort of reflection on at the end, where we go to some of the materials that she provided us with. But we want you to feel safe globally across all three of those domains. Again, Rebecca has mentioned this already, but some of the topics that we'll be covering within this training potentially may provoke memories, feelings, and emotions in you that could be uncomfortable. And what we'd like to stress is we will do our absolute level best to support you if that's the case. So we will never force you to go beyond where you feel able, and if you are at any point feeling like you are in an uncomfortable place and you no longer feel emotionally safe, then please, we will sort of reserve the permission for you to ask for a timeout or a pause, and it may be that we need to do that, and that's okay. We'll support you through that. On the plus side, it is a great opportunity for you to try out new ways of communicating and ways of dealing with very difficult situations. And let's be clear, these are not difficult situations for you as individuals. These are difficult situations for all clinical practitioners. We appreciate that this is a challenge for all of us to some degree. So this is a great opportunity where actually the person representing your patient and their relative, they are with part of the simulation team. So there is no risk clinically for anything that happens within simulation. All of it is purely orchestrated for your benefit within that safe space. So whether things go well, whether things go less well, there is learning to be had from that. And it's not about whether we are able to achieve perfection in simulation. It's about how what happens in sim is then reflected on, and we will think about a way to make it better next time. So it's about how we build our skills and our capabilities. And this is a great opportunity to do that where there is no clinical consequence. This is something that I think for all clinicians we need to work on. So I know as a nurse myself, whenever I was kind of asked to reflect on my own strengths and weaknesses, I was always more comfortable exploring my weaknesses. Most clinicians are terrible critics of their own practice. We all find it difficult to accept the things that we do well to some degree. So what we would like you to do is try and fight past that natural instinct and be proud of the things that you do well. And if you are observing one of these simulations and waiting for your turn to take on a scenario, then we want you to remain actively involved in the learning, because what we really want you to do in the discussions afterwards is to be able to support your colleagues and to help them to recognise just how good they are at what they do. This is not a training mode where an expert will tell you how to do your job. Now, that is not to say that when you do the course there will not be expertise to draw on, but very much it is a collaboration between the expert faculty, that might be Rebecca or one of her team, it may be some of the sim staff, and your own life experiences, professional experiences, reflections, ideas, attitudes. So it's very much we will all learn together. We may ask some questions to spur on your reflection, we may make some observations, but actually we are going to rely on you sharing your thoughts and ideas with us, and then we're all going to learn from that. When we run a simulation course, and for you guys it's going to be over a sort of a half-day period. Within that half day we will aim to run 5 separate simulations. Now each of those simulations will last for somewhere between 10 to 15 minutes. Each time we run through one of those 10 to 15 minute scenarios. We are then going to take you out of the sim space and we're going to bring you back into a teaching room where we will have a conversation. That conversation we often label as something called debrief. Debrief is a discussion, it's a reflection, and that takes a little longer than the sim itself. So generally what we'll find is that we might simulate for 10 minutes, but we'll probably be talking for 20 or 30. And then we'll do it again. And we will continue that process, because each time we share our reflections and share our thoughts, what generally happens is that next group that are going to go, or the next individual that goes in to do their sim, will adapt their practice accordingly. So generally what we find is that over the course of the half day, people's practice subtly improves with every single cycle around this sort of debrief practice continuum. So what we would hope is that by the end, we're all taking on some of the lessons of some of the previous reflections, and we're all that little bit better equipped to go out and deal with difficult situations going forward. Because actually, the training will be conducted here in centre, but actually the value of it is what you take away with you and take you back into your own practice, so that your patients, your relatives, your colleagues can get the benefit of that. That's where the true value lies. How your practice tomorrow is better than today because of attendance at the training. So confidentiality, I've mentioned this already. I'm sort of speaking out of turn. We won't speak about anybody's practice outside of the training session, and what we would ask is that you do the same, so that you don't share the specifics of the training with colleagues who may be attending on future sessions. That's not because we're trying to trick people or we're trying to hide anything, but purely because real life clinical practice happens in the moment. So what we don't want you to do is to tell somebody who may be coming in the following week, the scenarios were about X, Y, Z, and so on, so that they have time to fully prepare. And actually what we're seeing is not really kind of them experiencing it in the moment, but them kind of reflecting on their homework. Respect, well, you know, we all have our different ideas, we all have different attitudes, we all have different beliefs. We should, as a group, respect each other's ideas and points of view, and as I say, come to some shared learning because of that. So there's the rough structure. I think I've mentioned this already. There's the rough structure for your half day, whether that's a morning or an afternoon session that you'll be attending. So when you arrive in the centre, we will introduce you again to our team and to the space that you'll be working in. We'll work through those 5 separate simulation scenarios and associated debriefs over the course of the half day. And then at the end, we will ask you to just share your thoughts with us in a post-course survey, and we will wish you a pleasant rest of your day. So that's a very sort of brief kind of structure of what we'll be doing when you actually attend the course.
So this relates to the reasons really why we find these conversations challenging. What is it about them that makes it so hard? And there's, as you can see there, personal, societal, professional aspects, if you like. In communication workshops, we tend to refer to these as barriers. So you may find as a healthcare professional that there are some personal barriers in place, and they could be things that affect you. So you may have a relative that's unwell, or you may have somebody that at home that's dying, something in your personal life that's affecting your want or your need or your ability to go and have these conversations. So yeah, you can see some personal factors here, being that nobody likes to give or receive bad news, and that's probably because it's uncomfortable. It's not a nice feeling to make somebody upset or to feel as though you've contributed to somebody feeling upset. You don't want to see a patient in pain. You don't want to see that they're upset. Our own feelings about illness and death If our personal belief is that it's not something we talk about in our cultural belief or personal belief, then why would I do it at work? Why would I talk to a patient about it when I personally don't believe it should be done? You may see barriers, you may recognise this in yourself or your colleagues of not wanting to get too close to a patient or a family member. So you build a professional wall to protect yourself. And sometimes that can be intentional, sometimes it's necessary. There may be times to protect yourself that you avoid having these conversations. Sometimes it's because you don't want to get too close. But when I talk about intentions, what I mean is if, for example, you've found that you've looked after dying person after dying person after dying person, or you're looking after lots and lots of young people all the time, or lots of cancer, whatever that is that's taking its toll on you, it may be that you say, actually, I don't want to do this one. This is too hard. It's too much. And there's a barrier there. There's a factor there that stops you having those conversations. So sometimes that fear is there for a reason. And that touches on to concern about personal survival. It's very difficult to look after patients that maybe have similarities to yourself. So whether they're your age, whether they've got something that's similar to what's going on in your life, that can be quite challenging. Sometimes if they've got children the same age as your children, it can kind of reflect a sense of your own mortality back at you. That's quite challenging. And again, a common one for healthcare professionals, you worry that you may not have the support from your peers, your colleagues, your family at home, and you think, if I've got to go and have this conversation, I know I'm going to be upset, and today's not great because staffing's not very good and I'm going to have to carry on and so on. So there's lots of different examples there of reasons why personal factors can affect these conversations. Professional factors there, again, I don't want to go through them in too much detail, but you can see fear of blame, fear for patients may blame you if you're the one that gives the bad news. It might hinder the relationship you have going forward. So there's a fear of causing harm almost. As a result of that, sometimes to avoid having these conversations, we may focus on things that we can fix, because we know with death and dying, can't change that. The outcome is still going to be that sadly the patient is going to die, and there is nothing else that we can do to stop that from happening. And that's a real sense of helplessness, that we can't fix it. So what we do in those examples is we focus on things we can fix, which again is a blocking behaviour for these conversations. You're going to focus on the numbers you can work with, so that you don't have to have the difficult conversations. Again, fear of not wanting to get a reaction, upset somebody. Fear of not knowing what the answers are. If a patient asks you, am I dying? That's always really tricky, because you may not know, and you don't know how to deal with that, so you avoid it. And we've discussed the other two, the expressing your own emotions. Is it okay to cry in front of somebody? And then fear of taking up too much time. Well, that's a pretty tough one in the climate that we're in, but hopefully all of these things we can have some conversations around on the day. Societal factors, again, another challenge to having these conversations. So these come into play really more so, I feel, when it comes to the cohort of nurses that we're running these scenarios with. So international nurses, me and my colleagues were part of a group of professionals that were working on the International Nurses Fundamentals of Nursing course. So a lot of you may recognise me, and on that course we discussed a lot of cultural challenges that we were faced with around death and dying, and around talking about dying, around care after death, about the physical contact you have with a patient's body when they've died, and how that varies from your home countries to a predominantly white British society or health National Health Service and the expectations that we have of you guys coming over to our country and what that looks like. So there's lots of factors there that you may find challenging, and I'm hoping that this simulation really supports you through that. Yeah, I don't want to go too much into them because they vary quite a lot, those societal factors. Paul, is there anything that you wanted to add with that?
As I say, today really is just a sort of an introduction, just to get you kind of a taste of what to expect when you actually attend the training. So no, I think that's a lovely summary. Thank you, Rebecca.
That's okay.
This is probably one of the most important slides in the presentation now, because this is your opportunity, whilst you have myself and Katie and Rebecca on the call, to ask any questions that you might have, so that we can settle any fears, answer any uncertainties, make you feel positive, and hopefully have you looking forward to attending this training later in the year. So I will hand it over to yourselves.